Uh, Thank you, Natasha. Uh, see, uh, the quiz is one of the most well-attended sessions of the conference. I wanted Natasha to be the host for that because she has the capability to do that, and she'll make everything colorful. She looks colorful, right? So thank you everyone for the participation. The next session is going to be the AIOS National Symposium. Dr. Lalit Verma is going to be the chairman for the session. Sir is here. Dr. Namrata Sharma is going to be the co-chairperson, and I'll be the moderator. And we have the best faculty from across India who will be sharing their experience with you. Please stay back. Now we come to the one of the main sessions in Drishti 2023. This, after Dr. Namrata took over as the scientific committee chairperson of AIOS, what she has planned is that there will be an AIOS symposium in each and every state conference that happens across India. I mean, we are lucky to be one of the first to be conducting the AIOS National Symposia. If you can see the list of the speakers, we have the best of the best speakers from across India in this symposium. I request Dr. Namrata ma'am to take over and carry on with the session.
Thank you, Srini, and thank you everyone for having this AIOS National Symposia. Thank you, Srini, for doing one of the first AIOS National Symposia. It was planned to be the first one, in fact, and chronologically, your Kerala comes in the last week of November. We are still in the nostalgia of the Kochi conference that we had, which was very well organized by Dr. Sai Kumar, Dr. Sasi Kumar, Dr. Srini, Dr. Radha Ramanan, Dr. Gopal Pillai. And again, this is a wonderful venue. So we are going to be, and Srini has very aptly titled this as Update on Latest Advances in Ophthalmology. And it is my pleasure to invite the first speaker, again a very good friend of mine, Dr. J.K. Reddy, who is going to be talking about making laser refractive surgery affordable, slit lamp based trans-epi PRK.
Thank you, Dr. Namrata. Very good morning, and this is a very interesting thing which we are working for almost for a long time, but we are able to do that with a, it's called CDO. CDO is
Anand audio.
Yes, yes, some small loose contact. That will be there everywhere. Yeah, that's fine, just I don't. This one is more like an experiment, that's like out of curiosity. So this is a sit-in laser where patient won't lie down, they sit and they get the excimer laser. Is it possible to do that? That's one, our curiosity. Is it possible to make the patient sit there, get the procedure done and go home instead of lying down and doing all the things? So this is a machine, very small, compact machine, very small one. It just fits into 6x6 room or 6x8 room. And repetition, this frequency is 800 Hertz and 0.5. These are all like any new modern excimer laser. With active eye tracking, flying spot, and fractional ablation, and this as usual. See, the specialty of this laser is this one thing which is very unique to that. No other company is having is the beams, the laser beams which fall on the cornea are parallel. Most of the lasers, they come with an angle. From the object, it comes with an angle. So here, this specialty of the laser is these beams comes parallel to the cornea. So that's one this is called parafocal objective lens. That's a very special one in this laser system. And this is a very compact workstation. As you are sitting in the position, there is no cyclotorsion. We don't need to worry about that. Patients are very friendly because they got used to slit lamp examination. Frequently, these myopic patients, so they don't feel anything different you are doing for them. And very complex, there is very less complex mechanics like moving the bed up and down. All those things are eliminated, totally eliminated. Those like the mic didn't work like that, loose contact, so bed is not moving up or left, right. All this they don't is less dependent on environmental influences like humidity. All those things are very much controlled in this laser. So this is the machine, actual machine. Peter, Anand, video is not working. Say, hello? Yeah, yes, open with wall. That's good. Yeah, now it works. This is a compact machine in a small room, 10 by 10 room in my OPD. This is the first machine in the world. They gave me, they designed and developed, and they spent a lot of money on that. And they gave me for demo. This is a delivery unit, and this right side box is the main laser unit, and it looks like that. So this is just a demo. This is not a real patient. This is a demo how it works. So you just put a speculum for the patient, and you put on the just like slit lamp, okay, just like slit lamp, but we strap them so that because there is no Z movement, we call it as when the patient moves back and front, it should not happen. So that's we call it a Z movement. To arrest the Z movement, we put the speculum, and focusing is very easy. You have to focus that 2 lines. That's a monitor. No, nothing. You don't see anything. It's just like a robotic surgery. What they do, Da Vinci, general surgery or laparoscope. You just look at the monitor and do it. Even we don't need to whatever. You don't need to see the through the slit lamp or optics or nothing necessary. This is the actual laser firing now. This is the actual patient. So when the patient moves far away, it will stop and it fire. If you see carefully, the laser beams are coming line by line. They don't come at an angle in this laser. There is eye tracker on both the sides. And this we tried because we are experimenting. We have tried whether it's possible to do without a speculum. That's our issue. We tried and it's possible. Even you don't need a speculum, you put a few drops of paracaine and sit the patient, and we are able to do that even without speculum. This is captured in the video, infrared camera. No speculum, nothing. Patient just looks straight into the aiming beam. So the laser starts, the eye tracker works, and the laser starts firing. And whenever there is a misalignment, laser automatically stops. And this is the actual surgery happening, a video. And we tried, as usual, we select the patients of, we don't select straightforward cases. Initially, we select which are, there's some criteria. So Thiel-Behnke syndrome with 800 microns corneal thickness. So in the AOCT pictures, we did a 250 microns of PTK for these patients. And this is the post-operative results. So all the family members came. After we did first patient, 4 of their family members came for surgery. We did all 4 of them. And these are results. Of course, it recurs after 5-7 years, and doesn't matter, again we can do it. And this is another patient in their family, 1 brother, 1 sister, the other another patient. And this is a few cases of hyperopia. We did it, this patient minor plus 3 diopters. So we did unilateral plus 3 diopters. So we did a PRK for this patient in this same machine. So this is like the concept is just we should keep on, we should not think that what is available in the world, and we should not follow the same thing. Then nothing changes in the world. We will deteriorate over a period of time. We should always think what can be done and keep on pursuing. This is my 15 years old, 20 years back when Babu Rajan told that this is possible, that the idea was there in my mind when I'm listening to Dr. Babu. Then we keep on asking many industrial people. Ultimately, one gentleman, he accepted, Mr. George Hong, so he made it. So this is so whenever you keep your mind on analysis, looking at the results, try to analyze and all that, you cannot find the truth. The truth is only perceived by a blank mind. You have to look straight without any thoughts, without any knowledge. Then only you can see the truth, what's happening and what is possible. Thank you very much.
Thank you, JK sir. See, I'm proud to be his student, one of the most innovative minds in ophthalmology in India. Ma'am, any comments?
No, I think Dr. J.K. Reddy, it's again mind-blowing like always. Every time it's a pleasure to look forward to your new innovation, and again, this is yet another frontier. You move ahead of everyone else. For keratoconus cross-linking was done on laser, and now it is, PTK which is being done on laser, and otherwise laser being used on slit lamp. So many congratulations for that.
Thank you. Thank you, Dr.
Thank you, sir. Next, I invite Dr. Rashmin Ganti to speak on what is new in optic neuritis. Dr. Rashmin.
Thank you so much. Thank you, Srini. Thank you, entire team, for this very kind invite and to be part of this very well-crafted symposium. Thank you, ma'am. So the reason I wanted to talk about what's new in optic neuritis is because now the ophthalmologist, we have become again the center point of management of optic neuritis, and I'll tell you how. But I would like to start with the old concept. This was like maybe a century ago, where a British philosopher, neurologist, Walter Bailey, thought that optic nerve is like a tube which connects the eye to the brain, and through the eye it gathers all the evil spirit which goes through the brain. And optic neuritis might be a manifestation that the tube is not functioning well and evil spirit is all gathered, accumulated. And what he thought is that this evil spirit can be drawn out like a vapor from the head, and his therapy recipe for this was to say that why don't we ask the patient to comb his hair 3 or 4 times a day, which will draw the spirit out and the optic neuritis will improve. Obviously, he didn't think about a group of patients, if they develop optic neuritis, what they will do. But from there, we have come a long way. And now it has become very relevant again for us to know what are the current concepts in optic neuritis. Why is that? Because we always thought that optic neuritis is a disease of a young female, much more common in Caucasians, not so common in Africans or Asians. That generally they'll have a very mild visual impairment on presentation. Retrobulbar neuritis is much more common, and they are likely to be unilateral. All this has changed now. We now know that optic neuritis, the diagnosis, it will be always been differential at any age group. They seem to be now presenting much more with a bilateral involvement and much more disc edema than we thought initially. Also, we used to be taught that MRI scan, if you do it, it's okay. If you don't do it, it's all right. It is just for prognostication for multiple sclerosis. Steroids, if patient agrees to take it, it's all right. Otherwise, at the end of 6 weeks, patient would have equal recovery even without steroids. Again, that has changed. And why that has changed? Because now we see more and more of the optic neuritis, which is because of antibody which are circulating in the blood, which are affecting various parts of the structure of optic nerve. There are 2 antibodies which are known, and more antibodies are being looked at to see why there is so much of variation in presentation of optic neuritis. The 2 diseases which are known, or 2 antibodies which are known right now, is causing neuromyelitis optica, antibody to aquaporin 4 water channels, and MOG antibodies. So why our role becomes important? Because now these patients don't complain of pain. A typical feature of optic neuritis seems to be that patient would have pain which is aggravated by eye movement. But the patient who develop optic neuritis because of these antibodies, they have less complaint of pain. They seem to be having much more disc edema than the other patients. Generally, both eyes are affected, and the vision loss is severe on presentation and may not improve so readily. The other symptoms that we should be asking for is uncontrollable vomiting and hiccups, and I'll again explain as to why these patients complain of hiccups. Is because the area of the brain which are affected in this antibody mediated optic nerve damage are different from what are traditional, described as traditional areas of the brain which are affected in patients with optic neuritis. The dorsal midbrain area, area postrema, so area around hypothalamus is affected in these patients, and that's the reason why they complain of this hiccups and vomiting. The other important reason why we should be vigilant about these is because if we alert the neurologist saying this looks like antibody mediated optic neuritis, then there is a threshold for starting plasma exchange is low nowadays, and if now large studies are still pending, awaited, but if plasma exchange is done within the first week of the attack, then there is a thought that these patients, you have saved them from paraplegia, a debilitating neurological problem. So plasma exchange, IVIG seem to be now way to go. Also, even if patients don't get plasma exchange, these patients would require one of these steroid sparing agents like azathioprine or rituximab for a longer period of time. This was all about NMO or neuromyelitis optica or Devick's disease. A similar antibody which is causing optic neuritis is MOG. Here, the MRI will show that the optic nerve has become much thicker than usual. So what it tells you is that, as I said, ONTT said, yes, if you can do MRI, great, you will be able to prognosticate. But now MRI becomes extremely important because MRI itself will give you a clue whether are you dealing with antibody mediated optic neuritis. If you see areas like chiasm and optic tract getting affected, you know that you are dealing with NMO. If the optic nerve is thicker, what is described as perineuritis, you know that you might be dealing with MOG related optic neuritis. So, to summarize, all patients who we think has optic neuritis now should get MRI brain in orbit with contrast with appropriate sequencing. So you should alert radiologists that you're thinking of optic neuritis. ONTT said that if you did give a treatment, it's fine. If you didn't give treatment, it's fine. Now every patient who is suspected of optic neuritis should get steroids because you're probably now preventing or delaying the neurological damage and lower threshold of plex. Now, why we are important in all this is because it's we who will be knowing that patient has a bilateral involvement, one eye involvement might be lesser. It will be we who will know that patient has disc edema and that patient has profound visual impairment on presentation. So if we are able to alert neurologists about all this, we know that we have done a lot of good for the patient. I thank you, Srini and Dr. Amrita, once again for the kind invite.
Thank you, Dr. Rashmin. See, when the AIOS National Symposium was planned, I wanted the best of the best, and undoubtedly, Dr. Rashmin Gandhi is one of the best, or maybe the best neuro-ophthalmologist in India. Thank you, Dr. Rashmin.
Thank you.
Next, we have the great Dr. Santosh Honavar. Yeah. See, Dr. Namrata is the most energetic, most powerful, the most academic person in the whole of India, and I'm really proud to be her student, and she was kind enough to be very supportive to KSOS in all our activities, and ma'am will be speaking on what is new in corneal surgeries.
Thank you, Srini, and I would like to thank the sponsor, CIPLA, for sponsoring this session. And I would be talking to you about New Frontier Unleashed, which is the biosynthetic cornea. Now, in our country, corneal blindness is the second commonest cause of blindness only after cataract, And so that is why it becomes very important. And we do have limited availability of the cornea in our country, and there's paucity of good quality donor tissue. So this is something which we've worked with our Swedish collaborators, which is a bioengineered porcine construct double cross-linked cornea, which is clinical grade type 1, and it is doubly cross-linked. This is what it looks like. It comes in 12 millimeters diameter with thickness of 100 to 500 microns and has a shelf life of 2 years in the bottle, but has longer when in the eye. And it has gone through all the quality check, including all the investigations like in vitro, ex vivo, in vivo studies and biocompatibility issues. And when you compare it with the human cornea, only the fibrils are a little thicker, and this is how it will look on histopath. So this is your biosynthetic cornea, which looks absolutely acellular. This is the porcine cornea, which is intrastromally implanted, and this is the human cornea. So except for the fact that it is acellular, there is actually no difference between the two, and that too it is inert. And this is how it is implanted. So a femtosecond pocket is made with the help of the femtosecond laser, and this is a keratoconic cornea. This pocket is subsequently opened with the help of the lamellar dissector. This biosynthetic cornea is triphined with the help of trifines, as you would trifine a normal cornea. It is folded just like we used to fold the olden intraocular lenses, and then is placed intrastromally inside, and subsequently is unfolded and then is placed inside right up to the edge of the keratectomy site, and this is followed by a bandage contact lens. So actually there are no sutures also in this case. This is how it looks like on post-op day 1, sandwiched intrastromally, and a BCL which is on the top. This is yet another case of keratoconus and pellucid marginal degeneration both. So in this also a pocket is created, and this patient also has a cataract, as can be seen here. And because there is a pellucid present, the pocket goes right up to the periphery, because that is the thinned out portion. And and then subsequently again this pocket is opened up with the help of the dissector. This pocket is opened up with the help of the dissector, and you can see also in the microscope, operating microscope, intraop microscope, that the implantation of the biosynthetic cornea is then done. And then here you can go right up to the edge of the thinned out portion, because you don't have to suture there. Then subsequently this is the cataract surgery which was done 3 months later in this patient, and all that you can see is the rim which is present, which is a very thin rim and doesn't hamper the visualization. This is again the post-op picture. Yet another case of keratoconus where this biosynthetic cornea was done, and notice that the Kmax of 85.9 diopters is there, and it is a large cone. This is the post-op picture, and post-operatively it decreases to 57.1. So this is the pre-op picture, and this is the post-op picture, and it regularizes fairly well. And also increases the thickness of the cornea from 280 microns to 570 microns. This is our longest follow-up, so all that happens is that you can see a faint rim which is present all around, very much like your intacs or intrastromal channels, and this is 7 years down the line. This is yet another case which shows that the thickness increases, and this is the AIOS of the same. Now this was a case of post-LASIK ectasia, and in this post-LASIK ectasia we actually lifted the flap up, and then to reinforce this we created a pocket all around just to fit the biosynthetic cornea there, and subsequently the biosynthetic, notice that this is so thinned out here, in the recipient bed is so thinned out, and the biosynthetic cornea is placed now in between to reinforce the thickness of the cornea. And because of this thinned out cornea, probably the ectasia also occurred. So this is the post-op picture of the same, and this is again 89.2 diopters increased to decreased to 50 diopters, and 241 microns increased to 581 microns in post-LASIK ectasia case. This is yet another case where you can't use femtosecond laser because of the corneal haze or the corneal opacity. So you can do dissection with the microkeratome or can do manually. Again, this is the biosynthetic cornea which is being placed here, and here you can glue it because you can't, it's difficult to put sutures through this synthetic cornea. So this can be glued and can be pasted, and then a bandage contact lens can be put. This does take time to epithelize, 2 weeks as opposed to 7 days otherwise, but then it gives good results in these cases also. Now we've done in over 70 eyes, and all patients have had good best corrected visual acuity of 6/12 or better, with no rejection, inflammation, vascularization, scarring. This is the confocal microscopy above and below it, which looks normal, endothelial cells and nerves. And I think in future, what we are looking at is that we don't require any eye banks, any media, any laminar flow hood. I know this is far-fetched, but I'm sure it will happen. I hope it happens in our generation, because we've been hearing right from the beginning that there's paucity of good quality donor tissue. So it is potentially safe and simple surgical approach, not dependent on human donation, no graft rejection and failure, no suture-related problems, no eye bank facility is required, and it does not preclude a human graft transplant if required, although we didn't have to do in any case. What we are now working in our lab, and ICMR has sanctioned a project for the same, is we are trying to grow endothelial cells on this stromal construct to make a complete corneal construct. And I think that is going to be the future of cornea. So, and this with our Swedish collaborators and Iranian collaborators, we published about this in Nature Biotechnology, which has an impact factor of 68.1. And there is a long wait for all the children there and all the patients there. And I think what is going to be the future is, just like IOLs you take out from IOL boxes, from bottles you will be taking out biosynthetic corneas and will be using them as easily as I have showed you. Thank you very much for your kind attention.
Thank you, ma'am. See, when all these new technologies come, the question there is, what about the cost? See, as of now, if this procedure has to happen, what would be the cost, and what do you project over?
So as of now, there's no cost to it because it's a part of our project, but I'm sure because corneal opacities and corneal pathologies which require corneal transplantation generally are prevalent more in the socioeconomic group, which is not very elite, or in low to moderate socioeconomic group. So I think the companies will bring down the prices, because otherwise it doesn't serve the purpose. So the price has to be on the lower side, and we are going to be working on that also, so that the expense is not too much.
Thank you, ma'am. Thank you, ma'am, for that great presentation. Next we have the Chairman Scientific Committee of All India Ophthalmological Society, the one and only Dr. Santosh Unnavar. The General Secretary. Every time you think of Dr. Santosh Unnavar, you think of science only. So, and sir is the Honorary General Secretary of All India Ophthalmological Society, and he's doing a wonderful job with so many innovative programs. And I think sir will be speaking on targeted therapy in ocular oncology.
Thank you, Srini. You went back to your old tagline. Well, I'll be speaking on something that is new, that is happening in the field of oculoplasty and ocular oncology, that is targeted therapy. Now, what exactly is targeted therapy? This is generalized medicine. When you give a particular medicine for a particular disease and expect it to work in everybody, that is not possible. It's not going to happen that way. When you stratify patients based on disease subtypes, demographics, and clinical features, and use biomarkers, then that is stratification. Go one step further, and that is personalization, and we are heading towards precision medicine, where there are molecularly targeted therapies. There are many types of cancer treatments, and targeted therapy can be based on molecular targets or organ-targeted tumor-specific drug delivery, which is intraorbital and intraocular, intratumoral as well. What exactly is targeted therapy? It is molecularly targeted therapy by definition, which is a form of precision therapy, which targets specific genes and proteins in cancer cells that help them grow, divide, and spread. Does not generically target all the rapidly dividing cells, thereby side effects of these treatments are going to be very less. There are hundreds of potential targets and hundreds of potential deliverables. This is a totally unexplored field. We are just scratching on the tip of the surface at this point in time. What are the aims of such a targeted therapy? You already know that it could be curative, it could be neoadjuvant where you have planned certain surgical intervention, and before that you want to do this to shrink down the tumor so that your surgery is less invasive. Adjuvant, after having done surgery, you want to make sure that you mop up the entire disease by using these drugs. And palliative, make the patient live longer and the quality of the life not to be affected during that process. The first step is always to identify the mutation. Like in basal cell squamous cell carcinoma, melanoma, sebaceous gland carcinoma, Merkel cell carcinoma, all these of the eyelid and the orbit, we already have several of the molecular targets identified. We know that these are the targets, and for each of this particular target, there is a drug. For example, in conjunctival melanoma, the mutational spectrum has already been identified. The basics are to identify what a particular drug is. There are IBs and MABs of targeted therapy. Whenever a drug ends with IB, that is a small molecular drug. Whenever it is a monoclonal antibody, that ends with MAB. That is how the drugs are designated. Now there is a nomenclature of monoclonal antibody policy 2022, which further classified as MIB, NIB and NAB. I won't go into the details. Now these are the small molecules that we are already using. Vismodegib and sonidegib for basal cell carcinoma. For squamous cell carcinoma, we use EGFR inhibitors or epidermal growth factor receptor inhibitors. Erlotinib is available in India. Anaplastic lymphoma, we have crizotinib. And for metastatic adenoid cystic carcinoma, we have pazopanib. Many of these drugs are becoming available in India for systemic indications, and we can use the same drug for orbit as such. This is vismodegib, which acts against the hedgehog pathway. This is a patient which was reported earlier with basal cell carcinoma multifocal, where there is a role for vismodegib. This controls the disease. As you can see, without surgery, most of these tumors have regressed and have remained stable, but it is a treatment that is long-term. The patient has to continue to take it. In certain situations where there is an orbital extension of basal cell carcinoma where the patient is inoperable, again you can use to temporize the situation. This is a patient where there is right eye wet ARMD, he can't see. Left eye, which was making him mobile, has been displaced up by this orbital tumor, but he is inoperable because of systemic conditions. So he was given erlotinib. You can see that the tumor has shrunken and his eye visual axis has been restored, so he is able to see as long as he lives and succumbs to other diseases. Now, it's said that people with ropes don't always have to hang. This is one such example of a sebaceous gland carcinoma, which is potentially exenterable. But now with targeted therapy, which is of course a combination of cisplatin and 5-fluorouracil, you can see that the tumor now has resolved to the extent that it is excisable locally. Only the medial 2/3 of the tumor is left. This was a variant of sebaceous gland carcinoma in the lacrimal sac. Somebody has done a DCR earlier. Now this patient has 20/20 N6 vision. Why exenterate him? With targeted therapy and then DCT and then stereotactic radiation, his tumor is gone and he is living on. Small molecules actually make a much big difference. We have many tumors that are being treated as such. Now this is an example of BRAF inhibitor, vemurafenib, which has been treated with use for orbital Erdheim-Chester disease. This was my own patient of thyroid eye disease, young patient with IgG4 overlay. He responded initially to intravenous methylprednisolone and then rituximab, but finally when he relapsed, what controlled him was bortezomib, which is a newer drug which is available in India, not very expensive. For neurofibroma type 1, earlier we thought that it was a surgical disease. It does look like a surgical disease. Now we have medicines for neurofibroma, not just plexiform neurofibroma, even optic nerve glioma that is associated with neurofibroma. We have targeted therapeutic agents. We have several monoclonal antibodies, rituximab for orbital lymphoma, and immune checkpoint inhibitors such as pembrolizumab for melanoma, which is extending into the orbit. This is from the literature. Nivolumab, conjunctival melanoma from the literature. My own patient with nivolumab, he had regional lymph node metastasis. He had multifocal melanoma recurrent in the conjunctiva. We got approval from the insurance company for regional lymph node metastasis. He started using it. 3 months later, you can see that the tumor is completely resolved. I didn't have to do any surgery at all, making it a case for possible primary treatment, at least of inoperable diffuse patients using these targeted therapeutic agents. In uveal melanoma, we have the entire mutational spectrum worked out. We have now classified uveal melanoma into group A, B, C, and D disease, each with a different prognosis. And for patients who have a bad prognosis, we can definitely use many of the treatment modalities which are being currently tried. We also have organ-targeted tumor-specific drug delivery system. For lymphangioma, we can use picibanil with good results. For eosinophilic granuloma, we can inject intralesional triamcinolone with complete remodulation of the bone over a period of time. For apical or orbital cavernous venous malformation, we can use intralesional bevacizumab with reversal of visual field defects. For lymphoid hyperplasia, benign reactive lymphoid hyperplasia, we can use bevacizumab injection and rituximab as well. And this is my own patient with orbital lymphoma, conjunctival component excised, residual lesion treated with perilesional rituximab. Of course, we can use that for retinoblastoma as well. In conclusion, I would say that targeted therapy has just put its foot into the field of ocular oncology, and we have a long way to go, I understand, but these are going to be the next level of care in oculoplasty and oncology. Thank you so much.
Thank you, Santosh sir, for this wonderful talk on targeted therapy in ocular oncology. Sir, please be there on the stay back on stage. It's a great privilege to have the Honorary General Secretary of AIOS, Dr. Santosh Honavar, the Chairman Scientific Committee of AIOS, Dr. Namrata Sharma, Mayday past President, and my teacher, Dr. Lalit Verma on stage. Thank you all for being part of the symposium. And next, we have Dr. Sumita Agarkar. Ma'am will be speaking on optical interventions in myopia, myopia correcting spectacles, and contact lenses. When I discussed the talk with her, I said, see, everyone wants to listen to what is happening and with myopia correcting spectacles and it's everything about it. She said, yeah, this will be good. Thank you, ma'am. Dr. Sumita Agarkar.
Good morning, everyone. Thank you to Dr. Srini and the organizing committee and AIOS members to allow me to speak in this symposium. I'll begin with a small tribute to Dr. Badrinath. And he did not teach me any pediatric ophthalmology, but he shaped my me as a clinician in more ways than one. So with that, we'll start with my talk on optical interventions. So myopia epidemic, as we all know, is increasing, and by 2050, we are expecting a huge increase in children who are going to be myopic. In our own study, Janani Shankar Netralaya, in schools, we have found that almost 25% of children are in private schools are myopic, which is a huge difference from what was reported earlier in 2003 and all, where it was just about 6%. So what are the strategies which we have? Basically in two large categories. One is optical and pharmacological, which is of course low dose atropine. So of all the optical intervention, these are the ones which are available in India and have been proven to be effective. Bifocal glasses, peripheral defocus glasses, multifocal contact lenses, dual defocus contact lenses, and orthokeratology. They have proven evidence-based effect on myopia control. So looking at bifocals and progressive addition glasses, so this is a possible mechanism that most of the myopes who, when they do near work, there is a higher lag of accommodation, or there is a high accommodative lag, which produces a hyperopic defocus, and this is a cue for axial elongation. And that's why the bifocal glasses were prescribed or thought. But it has not proved equally effective across the spectrum of children with myopia. At this point, probably role of bifocals is limited in children who have progressive myopia with high lag of accommodation. This is more than 0.75 diopter. And children who have esophoria for near, probably you can try bifocal add of plus 1.5 over their glasses. Multifocal glasses have not proven in COMET study any effective in controlling myopia. Now let's look at the multifocal or designs which have come which produce a peripheral hyperopic defocus. So if you look at this diagram, you can see that if you give a single vision glass, rays of the light are perfectly focused on fovea in the center. But if you look at the periphery, because of the oblate shape of the eye, you can see that peripheral rays actually are focused behind, and this produces a hyperopic defocus, which is again a cue for axial elongation. So if you can produce a defocus zone in the periphery to make it artificially or by producing a myopic in the periphery, then this cue for axial elongation goes away. So new designs aim to create this peripheral myopic defocus by putting a different kinds of interventions to produce this myopic defocus in the periphery. So the first lens which was introduced in India was by Hoya, which is a MyoSmart lens, and again it produced this defocus by multifocal segments which produce a myopic defocus of around 3.5 in the periphery. So it has a central 9 mm optical zone and a peripheral zone of 33 mm which has lenslets of plus 3.5 diopters, as you can see in this design here, and they produce a myopic defocus in the periphery. So company and they have data. We have the longest data for this particular design. They have 3-year data as well as 6-year data, and myopic progression and shows 60% efficiency in efficacy in controlling the axial length, and compliance and adaptation was fairly good with children, and I have the longest experience with this particular design in our clinic, and we do find good control of myopia with the MyoSmart glasses. There is another, Essilor has also come up with this. They have, again, this is based on the same principle of producing a myopic defocus, but here the defocus has been produced. It has by a concentric ring which is formed by aspheric lenslets. So optical element may be different to produce defocus, but principle remains same. Again, 60 to 70% efficacy in controlling myopia progression. HALT versus DIMS head to head. In only one study, HALT has proven a little bit better than Hoya's MyoSmart. And of course, there is another player in the field now, which is CARE technology, where a defocus is produced by incorporation of cylindrical annular refractive elements, and that's why that acronym is CARE. They have 2 different options available at younger and older children, and central optical zone is surrounded by these alternating rings of correction. Again, adaptation is good. We have little less data about this particular brand, but they are just entered the market, and probably we should have more information on this lens. This is in future, that there are same defocus can be produced by translucent dots which are incorporated in glasses, and they reduce contrast at the retina and do not produce defocus actually. And it modulates the on-off pathways at retina. It has been proven effective in both younger and older children, and this is not yet launched in India, but we expect it within a year to get launched in India. Now coming to the soft contact lenses, the dual zone soft contact lenses, where again there is a central distance correction and peripheral addition by producing a myopic defocus in the periphery. This is the only lens which is so far approved by FDA for myopia control. Unfortunately, not yet available in India. Future, we are looking at an extended depth of focus contact lens designs. Again, initial trials are showing promising results. More trials are ongoing in this, and it's not yet launched per se. Coming to orthokeratology, they are based on reverse geometry, and lenses are worn overnight, which produce a temporary flattening, and it also increases the peripheral hyperopic defocus and provides clear vision as well as myopia control. So not only eliminates the need for daytime spectacles, but also slows down elongation. Reducing the back optic zone diameter in these lenses increases the efficacy of myopia control. However, they are more effective in younger children who show rapid progression and on high myopes, where we have nothing else except orthokeratology or drops. However, microbial keratitis remains a concern. So what are the risks of myopia control strategies with any optical devices? We have little information on rebound. Ortho-K lenses have known to accelerate progression on stopping the lens use and infiltrates, and they are of a primary concern in our country specifically, where they're in. So where do we go from now? We know every diopter of control improves quality of life and reduces the risk later in age. So we should think about moving from prescribing single vision glasses, or at least offer the patients that. We have now increased options to choose from. It is a fast changing field, and I am hoping that with mass production, prices will come down. So to summarize, this is what it looks at this point in our country. Thank you.
Thank you, ma'am, for the great presentation. Next, I invite Dr. Lalit Verma, and sir will be speaking on 1, 2, 3 of anti-VEGF agents.
Thank you, Srini, and thank you, Namrata, Santosh, Namrata Sharma for designing this session. You see, once she became chairman of the scientific committee, she said that she will do an AIOS session in all the state annual conferences, which is a welcome step. But I don't know, because of multi-specialty session like this, how much impact will it have that I speak on retina, cornea, because we will have a mixed kind of bag here. But nevertheless, it has its plus points that, different specialties tend to put forward what's happening in the today's world. So I'll be talking of one of the most hot topic in retina, that is the anti-VEGF injections, which is today the bread and butter of all retina surgeons. How? Next, it's not. Okay. And I'll be talking this. This is not a research paper. This is just an overview of anti-VEGF agents. And on one fine evening, I thought I'll speak on 1, 2, 3, 4 of anti-VEGF. You see, anti-VEGFs have revolutionized the management of all these retinal vascular disorders, including DME, in fact, diabetic retinopathy also, NAMD, RVOs, ROP, myopic CNVM, so many. The first anti-VEGF which came with a big bang and went out with a very big bang also was Macugen. No longer Macugen is being used anywhere across the globe. Macugen, I once in one of the conferences labeled as a pure water only, hardly any chemical, this thing. So in today's world, I divide anti-VEGF into two parts. First generation anti-VEGFs, which are off-label bevacizumab, then we have ranibizumab, and then we have aflibercept. And so many biosimilars have also entered into the market of ranibizumab also. Aflibercept biosimilars are in the pipeline, and hopefully next year we will have so many of aflibercept biosimilars. Second generation newer anti-VEGFs have come up now, and these are very promising. These are led by brolucimab. These are all monoclonal antibodies, then faricimab, and then high dose of aflibercept, that is 8 milligram aflibercept. So this is the way I now classify anti-VEGF agents. The pharmaceutical markets are today flooded, and every company will come at your door and say, prescribe this one, this one, this one. And there's a tug of war going on between all these companies. Everybody is going to price it little lower, 100,000 rupees here and there. Anti-VEGF innovator molecules are also there, and biosimilars also there. Believe me, all of them work. All of them are reasonably good with some percentage here and there. And the current issue, believe me, as I see it, in anti-VEGF market is only one, and that's durability of the injection. Because patients are fed up today of going every month to the doctor, every month OCT, every month consultation, every month travel. Believe me, this adds to the cost of the injection. And newer anti-VEGF molecules are being developed primarily with single aim, that is to increase the duration of injections. So you see, there's a distinction between RCTs and real-world scenarios. RCTs may show excellent results, because RCT I label as a red carpet treatment, because here the injections are given to the patient as free of cost. But in real-world scenario, where patient has to pay from his own pocket, he realizes the pinch of that payment, and therefore compliance issue comes in. So as I said, there is a tug of war between all these biosimilars, and they are not only efficacious. All these biosimilars which are in the market, they are efficacious, but they are also cost-effective to the innovator molecule. So this is one example of one of my patient who did respond. You can see this edema coming down here, but again. And one day this gentleman brought a chart. Doctor Saab, how many injections will you keep giving? And believe me, sometimes this may create an element of distrust also. So injection. Not only they are physically problematic for the patient, but also mentally also patient has a setback in this. And I remember one of the bank managers asking me, "Doctor, is there any permanent solution for this? Can I come less frequently?" So at that time I said no, but today I can say yes. So I tabulated all the anti-VEGF which are available, bevacizumab, ranibizumab, and the lower line which is box, in red box. So this shows the approximate duration of action. So aflibercept is proposed 6 to 8 weeks of duration. Brodusumab is piped as, as 12 weeks. And the newest anti-VEGF which is in the market maybe in a month or so, 15 December is the deadline, this will enter India's market, faricimab. Although it's got approved in 2022 in US, but I labeled 1 month, 1, 2, 3, 4 means 1 month, 2 month, 3 month and 4 month. This is the durability of the injection. And the last is the cost of the injection. So if you see the last two molecules, less the interval or more the duration of injection, the cost tends to come down because patient tends to spend less. So these are the various studies, based on which a lot of these molecules got approval in NAMD, Anchor, Marina, View 1, View 2, Hawk and Harrier, Tenaya and Lucerne. And on the right side, I have listed 1, 2, 3, 4 of all these anti-VEGF injections. So I'll not go through this Marina Anchor. This was the first pioneering study of ranibizumab. For the first time, they showed that graph can go up. Up means patient can gain vision now. Not only maintenance of vision, but gain of vision. And this is the View study of aflibercept, View 1 and View 2. Then Hawk and Harrier for brodusumab came up. Then Tenaya and Lucerne for faricimab. Similarly, for diabetic macular edema, remember always 2 parallel studies have to go on for FDA approval. We had RISE and RIDE for ranibizumab, then Vivid Vista, Kite and Crestel, then Yosemite and Rhine. Again, 1, 2, 3, 4 of all these anti-VEGF injections. So I'll again skip this RISE, RIDE study, Vista and Vivid, and Crestel for brodusumab and Kite. These are the latest talk of the town, Yosemite and Rhine study for faricimab, where they claim that Q16 can be obtained in at least 70-80% of patients. So thus to conclude that, we have gone far from 1 month to now 4 months of injection, and this is a good step, a welcome step and a positive step. So world is, believe me, moving very fast, and every day so many studies are going on. So 1, 2, 3 months is primarily duration of action. We have moved from 1 month from bevacizumab to ranibizumab to 2 months of aflibercept, 3 months of brodusumab, and now 4 months of faricimab. The ultimate barrier, believe me, is the cost and the durability. And COVID era told us that we used to inject, at lesser frequency, but it did help. So molecules which have longer duration of action, the compliance improves, and hence the cost comes down, and treatment effect also is better. So thank you very much for listening to this 1, 2, 3, 4.
Thank you, sir. Thank you for the wonderful presentation. And now we have Dr. Kaushik Murali, who is the president of Shankara Eye Hospital Group, which is spread all across India, and the kind of volume Shankara does. I'm proud to be an alumnus of Shankara Eye Hospital, and nobody better than Kaushik to speak on. This is a latest advances session. He'll be speaking on what is new in ICAM strategies, community outreach.
Thank you so much, Srini. I think I'm humbled to be a part of this session where I have 3 teachers who taught me ophthalmology along the years, Dr. JK, you yourself, and Dr. Sumita. Proud to be representing something that is not commonly spoken about when you talk of latest advances, where we are talking about community eye care. So thank you again for considering this important enough for this national symposium. We need to remember that while we sit in this room, we are talking about advanced technology. Our country is considered to be an India and a Bharat in it. Now, I'm not sitting here to make a political statement, but rather to showcase that we need to be aware and remember the diversity that is there in terms of access, availability and affordability of healthcare. It is not the same for what it is for us as for a majority of our population who will still struggle to get a simple eye examination done or even get a pair of spectacles done. With that in mind, we need to figure out a way how we can enhance our outreach. This is a picture from the last 1 week of some of the outreach activities that have been going on. And this is the India that we should continue to remember while we serve our patients who walk into our clinics every day. What we've done to move on from using a torchlight and a vision chart at the screening camp is to create a handheld application called Service. This is the Shankara Electronic Remote Vision Information System. This is a handheld device that allows, it is available in 7 languages, that makes it easy for our field staff in the states that we currently are present in. They can do a household survey, they can complete their attendance, they can complete their administrative activities, and this allows them not just to share what screening has been done, but also generate a QR code. So most of these are illiterate patients where you tell them that you have to carry something. It becomes a challenge and you want to track this patient from the village to the hospital and back. So they carry a QR printer. This is handed over to the patient. At the hospital level, we are able to kind of analyze what has been happening across all our centers, across all the field workers, and look at how efficient this entire screening has been. This also, when linked to a GIS, helps us create hotspots. So what you see on the map on top is where the household surveys have been done, and the little red and orange specks show you saying that where systemic diseases have actually been identified. This allows more targeted interventions to be carried out in these households. We've looked to kind of also add in a little element where we thought, can we actually get a patient, our field staff, to capture a photograph of the eye using a simple smartphone, and can AI be enabled to actually help them identify what is referable cataract. In this, we are looking at somebody having a visual acuity of say 6/18 or less and still have a cataract and pick it up. This currently we're still working on the algorithm. The sensitivity specificity isn't that great, but it is definitely much better than a torchlight being used. Over the years, what has also changed is our shift in focus from cataract to other systemic diseases. So we partnered with a company called LebenCare to work on an AI solution. Again, look at referable diabetic retinopathy. So we looked at how the image could be classified and a simple AI report that could be generated. We also worked with a couple of school students because when you talk of community outreach, it's not just surgical care but preventive care. But again, we looked at saying that can smartphone images be used to actually detect amblyopia risk factors, and this again is something that we are looking to deploy in the years ahead. Teleophthalmology vision centers have been something that a lot of us in community outreach have been familiar with. Typically, this would involve a Skype or video call consultation where an image is transmitted and the doctor kind of chats with the patient. What we've done differently again is we worked with the University of Bonn and with now Remedio, who took over the company we worked with earlier, and we've looked at layering an element of AI. So here the fundus image is captured, that gets pinged, an AI report gets generated. What you see, those black blotches, are actually hotspots where the ophthalmologist can actually look more closely. And then sitting here in Bangalore for a patient in Virudhachalam, she can actually annotate and say that this patient has a grade of diabetic retinopathy that requires the patient to actually visit a hospital. This makes it much easier for the patient to not unnecessarily travel. What I've tried to showcase to you is a flavor of what is changing in the field of community outreach, because as ophthalmologists, I'm sure all of us will agree that our eye health should not be defined by where we live, or what access or what our socioeconomic status is. So once again, thank you so much for having me as a part of the symposium.
Thank you, Kaushik. That was icing on the cake for this extremely informative national symposium. Namrata ma'am.
Thank you so much, Srini, for holding this. And if there are any questions, we still have 3.5 minutes, or any comments anybody would want to ask.
Namrata, do you plan to take it for entire 3 years, that all state level you're going to do this session?
So why are you in a doubt? Yes, of course. Yes, of course, we will take it up for all the 3 years. And thank you, Srini, once again. I think Srini has set the theme, latest and often.
As I said, this is a good positive step for including the latest in various subspecialties of ophthalmology. And this is a welcome step, which I couldn't do it, and she has done it.
Dr. Lalit Verma has taken AIOS to what it is today. Now we have, I can't call the next generation, but the next group. See, Dr. Santosh Unawara, it was a slip of tongue, like the scientific committee. But see, whenever we think of Dr. Santosh, it's that. But I'm really, really impressed with what he has been doing as a AIOS General Secretary. see, just go through what AIOS is doing now. I'm surprised and impressed. I'm really happy that he's a AIOS General Secretary now. Thank you all for being here. Yeah. Sinamol.
One question to Madam. Is this bioengineered cornea available commercially? Can we?
I have 100 with me, so if anybody wants to try, you are more than welcome, and it is not at any cost. So I have about 100 biosynthetic corneas as a part of the project. So that is coming free of cost. So if any of the cornea specialists or anybody wants to try, can try. But it will be available soon. They've applied already for CE approval, and it is on the way because it's manufactured by the Swedish collaborators. So first it will get CE approved, and then subsequently we'll apply for a DCGI approval.
Okay, Madam. Thank you.
Thank you. With this, we conclude this session. Thank you all for being here.